Okay. Hello, everyone. Thank you very much for coming to our booth talk. This is the first session of the day. The speaker will be Dr. Ratu Puri from Indonesia. She will speak on our Maestro2, how it is beneficial, how it is efficient for her everyday clinical workflow. Some of you already know our OCT, some of you may not know, but I hope this is a very insightful and very useful information.
Okay, good morning, everyone. So thank you so much for joining in. My name is Ratu Puri Paramita Sastradiwirja. I'm a vitreoretinal consultant from Bandung, Indonesia, from ICE Prime Center Clinics. So today I'm going to have a talk on multimodal retinal imaging, the importance of its application in clinical practice. So multimodal imaging, by definition, is the use of more than one technological system to acquire images concurrently or at a short period of time that complement one another. This is the key. Complement one another for the purpose of diagnosis, prognostication, management, and monitoring of disease. The multimodal imaging has some features. The first one is rapidity of acquisition, then high reproducibility and reliability, and last but not least is the non-invasiveness. There are types of multimodal imaging that has revolutionized the clinical practice for ophthalmology, mostly for retinal specialists. The first one would be the OCT. We call it an optical biopsy because it has the ability to help us to see in vivo imaging of the retina in cross-section. Secondly, we have fundus photo. Fundus photo has been around longer than OCT, but it's still relevant today, especially for educating the patient and also to correlate the findings of OCT. The traditional fundus photo can capture around 30 to 60 degrees of retina. Meanwhile, the newer ultra-wide field fundus photo can capture around 200 degrees of the retina. And next, we have the OCT angiography. Although the use so we were in OCT angiography. This OCT angiography is useful to image the retina and choroidal microvascularization with depth resolution. It is very useful for patients with retinal vascular diseases like diabetic retinopathy, RVO, and of course the AMD. And we have the infrared, or we call it an NIR, or near infrared reflectance. It's helpful to visualize subretinal alterations of the subretinal structures, photoreceptors, RPE, and the choroid that didn't show on fundus photo. And next we have the autofluorescence. Autofluorescence exploits the capacity of fluorophores in the retina. Fluorophores is actually a compound in the retina that re-emit lights upon light excitation. So if you see here in the image, there's this areas of hyper-autofluorescence that suggests that the RPE is sick. Because the hyper-autofluorescence shows a lipofuscin that usually inside the RPE, and when the RPE is sick, the lipofuscin actually comes out and then gives us the image of the hyper-autofluorescence. While the hypo-autofluorescence area here suggests that the RPE is dying or is not viable anymore because no lipofuscin left. Okay, so the last image that I showed in the previous slides was the dye-based angiogram. It's also considered a multimodal imaging. Although the use of FFA and ICG as a dye-based angiography is now declining over the years, but it's still the gold standard for us to assess the functionality of the retinal and choroidal vasculature. So I think I just need to stand here. There are numerous advantages of multimodal imaging. The first one would be the earlier disease diagnosis that will lead to earlier treatment and a more precise monitoring of progression of the disease and the ability to maintain vision, to name a few. But it also comes with some disadvantages, of course. The overwhelming integration of all the data, the higher cost of machineries, of cost per test for patients, and of course, cost of manpower. It also needs longer time if we want to do multiple images, and especially if it's done by different machines. The combination of the several imaging inside one machine is not impossible. One of the example of the machine, one for all machine, is this Topcon Swept Source OCT, we call it Triton Plus, where it combines OCT posterior, OCT anterior, true color fundus photo, fundus autofluorescence, fluorescent angiography, and also OCT angiography. So all the hassles that the aforementioned can be lessened. So what is the implications for multimodal retinal imaging for our clinical practice? It is an integral part of a comprehensive eye care, because relying on one modality only may provide incomplete information for the retina status. It's efficient. It can be used as patient education, so the patient can have a better understanding of the disease and enhancing patients' compliance for treatment. And it can be integrated into the AMR, so it's streamlined. We can have a streamlined clinic workflow. So in our practice as a retinal specialist or as a general ophthalmologist, I think one of the many patients that we see have diabetic retinopathy, of course. In this fundus photo, you can see the some exudates around the macula that is encroaching into the fovea. And you wonder whether this patient has central involving DME or non-central involving DME, because the management would be different. And OCT scans can tell you, at least in this scan, that the very central part of the fovea is actually dry. And juxtafoveal to it, you can see there's some intraretinal exudates and also some fluid over there. So in this case, if, say, patients still have good visual acuity, I won't do anything. I'm just going to observe the patient and then tell him to regulate his diabetes better, and have the patient come back in like 1 or 2 months. And if when the patient came back, it becomes central involving, then I'll do the injection. A patient with diabetic retinopathy also benefits from examination of OCT angiography, because sometimes the OCT angiography can show you, well, not sometimes, it's always, we can see what's happening, especially in the deep vascular plexus. So on the right upper part of the image, this is the OCT, the superficial plexus, the superficial slab of an OCT macular angiography, which probably not, you can't really tell anything from here, but as you see the deep vascular plexus in here, over here, you can see that there's abnormal blood vessels, teleangiectatic blood vessels that suggesting a microaneurysm over here. And on the bottom image, on the right side, you can see a proliferative diabetic retinopathy, where you can really, this is really highlighting the capillary non-perfusion or capillary dropout. Oops. Okay. And on this side, this is the capillary dropout areas. Okay. And on this image, you can really see that the vascular avascular zone has enlarged. That explains, we can explain it to patient about his declining of vision. It's because of the ischemia of the macula. This is a case of 32-year-old male with a handheld laser injury. He came in with a round reddish lesion on the fundus photo. And on the B scan here, we can see some intraretinal hyperreflectivity, subretinal hyperreflectivity on B scan, and we can see some OCT lesion on this, the outer retina slab and the choriocapillaries. After 3 times injection of anti-VEGF, you can see that the CNV is getting better. We can see less shroom, less fluid, and also you can see from the OCT angiography that the CNV is getting smaller. If we don't have OCT, if we don't have OCT angiography, we're not really can show the patient the results of his treatment, because sometimes the improvement in anatomical findings not really correlated to the improvement of visual acuity. And this is another case of a 61-year-old female with non-ischemic BRVO. The OCTA shows on the superficial plexus, it's relatively unremarkable, but as you can see, is something wrong with the clicker? Okay. On the OCT angiography, the deep capillary shows some telangiectatic vessels and the enlargement of the FIZ. The corresponding OCT B scan shows some cystoid macular edema. In this case, I definitely will inject patients. Another case of perifoveal telangiectasia or MacTel type 2. In this fundus photo, you can see the presence of, this is a bilateral disease, and you can see pigment proliferation and arrowheads here, and crystalline deposits around the macula. Another case of MacTel type 2 with Swept Source OCT, the upper part of the image can show you foveal atrophy with loss of outer retina, representing a late stage of disease. Can you see that this is a spectral? This is Swept Source OCT, where the penetration of light is superior to spectral domain OCT. You can actually see the choroid vessels better. I think I cannot move on from here. Okay, this choroid vessels better, and you can even see the scleral interface with the choroid over here. On the bottom part of the image, it's another patient who has MacTel type 2, demonstrating as typical cystoid cavities in the absence of macular edema. This one won't really show in the clinical picture of or a fundus photo alone. This one is a 67-year-old lady with stage 4 PFT or MacTel type 2. A fundus fluorescent angiogram shows diffuse leakage from telangiectatic vessels in the late phase. So you see, for one diagnosis, for even one patient, you don't rely on one modality only, because it can give you a wrong information of the patient. The same patient who has an FFA here, the same patient did a MAC OCT angiography. It shows a disruption and apparent widening of the foveal avascular zone due to the intraretinal cyst. And these telangiectatic vessels can be seen. I don't know what happened. Can be seen in the temporal to the FAZ in the deep capillary plexus. You cannot really see it on the superficial plexus, but the deep plexus, you can visit. It is visible. It's really visible. No CNV seen in the avascular zone, so the avascular zone is clean. No CNV there. Another patient, a 54-year-old lady with submacular hemorrhage who underwent pneumatic displacement with C3F8. You notice the gas bubble on the superior part of the macula. So this is the relevance of a fundus photo nowadays. Sometimes patient told the doctor, "Oh, doctor, I can see some bubbles. Is there something wrong with my eyes?" And with this fundus photo, you can actually tell her, "No, it's a gas bubble. It will go over time. You don't need to worry." On the B-scan OCT, it showed multiple fibrovascular PED, a double-layer sign, shroom, subretinal fluid, and presumed polypoidal lesion on the nasal part of the macula. As you can see here, it's over here. It's correlated with a sharp. It's not really sharp PED, but it's quite narrow PED over here. This is the same patient, After pneumatic displacement and 6 anti-VEGF injections, you can see that there's less submacular hemorrhage and reduced PED height, although you can still see some fluid there. So I still continue the injection for this patient. This one is an on-fast OCT image for patient with dry AMD. You can see that the image from over the years. On the macula, there's some progression of geographic atrophy. The patient visual acuity decreased from 2025 in 2016 to 125 in 2021. This is an image of fundus autofluorescence for patient with drug-induced maculopathy. You can see this, the pathognomonic speckled autofluorescence centered around the fovea. So in fundus autofluorescence, as I said before, you can see the integrity of the RPE because the lipofuscin, the fluorophores that's inside the RPE, now can be seen through the FAF as the hyper autofluorescent flex over there. That means the RPE is not die yet, but it's sick. And you see the hypoautofluorescence area there. It's showing that the RPE is non-viable anymore. OCT can be done in patients with uveitis. This one is an example of 26-year-old female with APM PPE or acute posterior multifocal placoid pigment epitheliopathy. I know retinal disease is always so complicated, the name. So you can see the bacillary layer detachment or ballad over here. That is a splitting of at the level of inner segment myoid of photoreceptors, leading to development of intraretinal fluid cavities. Fortunately, this patient, after given oral steroids, after 1 week, she gets better. So in summary, multimodal imaging is the combination of several imaging methods, each of which has different capabilities and benefits. It's complemented each other. It's been used for diagnosing and treatment of common retinal diseases such as retinal vascular disease, AMD, PCV, choroidal vascular abnormalities, uveitis, and tumors. It has an advantages of its high resolution, non-invasive imaging technology. It provides improved patient assessment, a better understanding of the retinal disease, and of course, it will lead to better management. In clinical practice, in our daily clinical practice, the multimodal imaging is important. It's an integral part of our comprehensive eye care. It's used for patient education to increase their compliance and adherence to treatment for a better outcome. It can be integrated with the EMRs, so it's very convenient. Some of the disadvantages of this multimodal imaging is some image artifacts, higher cost, greater acquisition time, and challenge to integrate all the information into one diagnosis. And future directions, of course, we all know that nowadays it's always the artificial intelligence going forward. But I think the caveat is we need to have a consensus about application of these imaging modalities for precise management, of course, personalized management for retinal diseases. Here I show you a short video of how convenient this multimodal imaging in helping me to have a correct diagnosis for patients. So in our clinic, we have, this one is showing a 3D, this is the Maestro2 from Topcon. It's very user-friendly, technician-friendly, and also, of course, patient-friendly because the acquisition time is very fast. You can choose whether you want to do a OCTA, fundus photo, or OCT. It also have anterior OCT. And after consultation, you can show the results in the convenience of your room. Like this. So patient will have a better understanding of the disease, and hence he will adhere to the treatment. Okay, I think that's all I can present. Sorry. Oops. Okay, for local ophthalmologists, if you have time, in June 1, please come to Bandung for a culinary feast because my clinic will hold a symposium and workshop. Thank you. 7 questions. I think we can just wrap this out. Yeah? Okay, great. Thank you. I really like Maestro2 because one, it's quite economic for you who just started like building a clinic and you wanted to integrate some multimodal imaging. I think this is a great value for money because you can have all those things, all the different imaging modalities in one machine. What I like about this Maestro2, if you do an OCT scan, the results in the ImageNet showing you the fundus photo, the OCT scans, and the quantitative measures of the retina. You know, not many machines can do that. So in one screen, I can show them the fundus photo, the OCT scans, and also the quantitative analysis. So I don't need to change like click to another windows or anything. So it's really convenient. So the majority of my patients is like 50 above with AMD, RVO, DR, and most of my clinics, 90% is a retina patient. And I found that they don't have any difficulties getting the scans and for the patients getting instructions, they're understanding immediately. So, and also for the technician, the learning curve is very low, I should say, because it's very user friendly and technician friendly. So I think it's a very useful addition for our clinic. Yeah.